Hey, welcome everybody. I am Rita Pearson, Executive Associate for Education and Meetings at the California Physical Therapy Association, and I will be your moderator for this evening. Thank you for joining us for Gait Deviations and Rehabilitation Strategies for Individuals with Diabetes. The schedule for today's live presentation has us ending at 8 p.m. When the webinar ends, a course evaluation will be emailed to you, and all paid registrants who complete the evaluation will receive CEUs for 2 contact hours. Please note we are recording tonight's presentation. A link to the video recording will be sent to you tomorrow. In order to make this presentation comfortable for everyone, please mute your phone lines to minimize background or unexpected noises. Also, please check the screen name on your video. We need to see your registered last name and your preferred first name. This will help us in checking attendance and calling on you to participate later this evening. If you need help changing your screen name, please send me a chat message. Now, I will tell you a little bit about our speaker. Dr. Salsabili is a leading expert in AI-driven rehabilitation with dual PhDs in physical therapy and human motion control from Purdue University. She has dedicated over a decade to researching and practicing diabetes neuropathy rehabilitation, pushing highly cited studies on gait and postural rehabilitation in individuals with diabetes. Dr. Salsabili completed 2 postdoctoral fellowships where she focused on AI applications in diabetes rehabilitation. Her work has been instrumental in integrating artificial intelligence into rehabilitation to enhance patient outcomes. With a passion for innovation, research, and patient-centered care, Dr. Salsabili continues to bridge the gap between technology and rehabilitation, shaping the future of AI-driven healthcare. So welcome back. Thank you for joining us again this evening. Do you want to start with your PowerPoint presentation?
Sure. Thanks, Rita, for introducing me, and thanks everyone for joining tonight. Let me share my screen here. Okay. So today I'm talking about the gait deviations and rehabilitation strategies for individuals with diabetes, current evidences and innovations in practice. So thanks, Rita, for introducing me. I'm holding 2 PhDs and 2 postdocs. Most of it focused on diabetes rehab, and then integrated later on my second postdoc with the use of AI. Currently, I'm very much interested in integration of the use of AI for not only the diabetes rehab, but also on the education of the physical therapists about the use of AI specifically for patient monitoring. And I'm very much passionate about the emerging technology, innovation, and patient-centered care into the PT practice. A few things about the parallel things that I did in Pivotal PT. I'm affiliated with this company, and this is the platform we're using for educating our students about the use of AI, in not only in the for the use of improving their clinical reasoning, but also for monitoring the patients and looking at the adherence of their patient. And so we're educating them on the use of AI with Pivotal PT. So it has an advanced motion tracking system, computer vision AI, and that is for giving the real-time feedback and also tracking the patient. The other part of it is the automated documentation that is very helpful for the improving the clinical reasoning, and we're educating the students on the use of that. So learning objectives for tonight, the first one is understanding the biomechanical and neuromuscular effects of diabetes in gait. The second one is identifying common gait deviations associated with diabetic peripheral neuropathy. Third is learning about the strength, balance, and mobility training for fall prevention and functional recovery. Evaluating evidence-based, task-oriented rehabilitation to enhance the functional gait, utilizing orthotic devices to support gait rehab, and integrating AI and wearable technologies into diabetes rehabilitation to monitor and improve gait patterns in the diabetes patients. So the first topic for tonight is diabetes gait related complications and mechanisms. So I'm starting with the reviewing some complications and mechanism, and then move on to the other learning objective. So the common complications that are associated with diabetes in general, one is the microvascular damages, and the effect of that is like a neuropathy, retinopathy, and then that can lead to the functional impairments. And the other one is the macrovascular complications, and that includes cardiovascular disease, stroke, or increasing the morbidity and mortality. And that both of them are highlighting the need for the rehabilitation strategies and improving the gait and also the function in the diabetes. So focusing on the physical activity, education, and lifestyle modifications are all like a part of the rehab for the diabetes patients. So more about the diabetic peripheral neuropathy. So diabetic peripheral neuropathy is a symmetrical, length-dependent sensory motor polyneuropathy, and which is attributed to the metabolic and microvessel alterations. And that is all due to the hyperglycemia and also concomitant of the cardiovascular risk covariates. So like the vascularity is under the effect of the hyperglycemia, and also the neurons, the neuropathy is the result of the hyperglycemia. The prevalence of the diabetic peripheral neuropathies can be as high as 50%, and that is very dependent on the age and duration of diabetes. And the effects are sensory motor and also the autonomic components on the nervous system, More about the pathophysiology. There are some chain of events underlying the pathophysiology of the diabetic neuropathy. So components of the metabolic syndrome also contribute to the diabetic neuropathy, and that is by causing the energy overload from excess glucose and lipids, and that is leading to mitochondrial bioenergetic failure and mitochondrial depolarization, loss of adenosine triphosphate as an energy source, and also accumulation of reactive oxygen species. So all together, this process leads to the impaired mitochondrial trafficking from the cell body down to the length of the axons. And so the endoplasmic reticulum stresses, apoptosis of the neurons, and axonal failures are all the pathophysiology of the diabetic peripheral neuropathy. So basically, in the right figure, you can see the chain of injurious events leads to the mitochondrial dysfunction, and that is causing the distal to proximal degeneration of the energy-starved axons and diabetic peripheral neuropathy. So PAD, peripheral artery disease, also contributing to the gait deviations in the neuropathy patients also. So PAD affects the 20 to 30% of diabetes, and that increases the risk of hospitalization, frequent falls, and gait deviations. So PAD characterized by the narrowed arteries and reduces the blood flow to the limbs. So other than the effect of the diabetes on the nervous system, it affects also the vascular system, and that results into claudication, muscle atrophy, limited limb mobility, and also may end to the sedentary lifestyle for the patients. So about the symptoms and clinical signs of the diabetes peripheral neuropathy. So traditionally, diabetes peripheral neuropathy can be either positive, like aching, burning, sharp or pressure pains, or negative, numbness or like a dead feeling, or like both simultaneously. So although the DPN affects the sensory motor and autonomic components of the nervous system, but it's also manifesting itself as a loss of protective sensation, intrinsic foot muscle, dysfunction and also can lead to the alteration in gait. So here you can see in the table, there is an effect of the neuropathy, there is an effect of the diabetes and a hyperglycemia through the neuropathy, first on the small nerve fibers. The symptoms could be burning pain, electric shock pain, and stabbing, or the hyperalgia or the albuminia, or affecting the large myelinated nerve fibers, making the sense like a numbness, tingling, and also poor balance. There are some evaluations for testing the small versus the large, like the damage to the small versus the large myelinated nerve. And we'll go through that later during the presentation. But overall, normal walking is the end product of the healthy neuromuscular skeletal system, and that requires both sensory input to modify the motor patterns and also the muscular output. And so that means DPN have a significant interplay with the gait disorders and the risk of falling. And so when there is a damage to peripheral nervous system, that can affect the control of the gait movement, may affect the muscle strength, for example, and in the joint movements as well, and that affects the locomotion and also the gait. And later on may end up to the increase of the risk of falling. So the implications for mobility, so the nerve damage have some consequences on the, some consequences, and that is contributing to the gait deviation. The vascular damage can cause us some like a higher risk of foot ulcers, and that elevates the likelihood of the foot injuries and then resulting in serious complications, even infections and amputations. So these two together can affect the gait and function and mobility, and that necessitates the rehabilitation. That is a very comprehensive approach, especially for improving the gait and balance, and also for reducing the risk of falling. So more about the gait biomechanics and deviations in diabetes. So there are some factors that are contributing to the gait deviation. So I have been through some pathophysiology, the underlying abnormalities. So sensory loss is one thing that I already talked about, like impaired vibration and also protective sensation. So other than the numerous abnormalities, like including the sensory loss, loss of the like impaired vibration and protective sensation, or the decreased lower extremity strength, force producing capacity, and there is some also alterations in the central nervous system, and that is contributing to the impaired gait in diabetes as well. So there are also some behavioral changes, and that affects the gait as well, and that is beyond simple functional impairments. It can be alteration in the mood and cognition. So there are some studies that demonstrated that unsteadiness in gait was the strongest association with the symptoms of depression in patients with diabetes. So both mood and cognition may alter the relationship between diabetes and gait. So there are also some studies that showed only 39% of the patients with diabetes have an like a report engaging in at least 30 minutes of moderate exercise 3 days per week, which comparing to the healthy adults, that is 58%, that's pretty low. So that means the effect of the mood and cognition and the association of the physical activity with the depression, symptoms of depression in diabetes patients. So other than these factors that are related to the pathophysiology, DPN, and also abnormalities, and also some effects on the mood and cognitions, there are also some factors that are related to the advanced glycosylation in the joints or in the other tissues of the body. And that increases the risk of ulcers, and that affects the gait very much. So in one study by the by some studies found there is a loss of skin thickness and increased sole hardness that can increase the local it may increase the local pressure. And so that sole hardness during the initial stages of the diabetes peripheral neuropathy that can increase the risk of ulcers. There's other studies about the effect of the glycosylation on the tendons, and so they found the increased thickness of the plantar fascia and the Achilles tendon, and they found that there is a trend of increased thickness of both the structures as the diabetes severity also worsen. Some studies also focused on the joint, and they found that the range of motion in the a dorsiflexion in the ankle and also the first metatarsal phalangeal MTP joint decreases in the diabetes patients, and that reduction is about 2 or 3 degrees, and then versus the other patients. So they reduce the reduction of the ankle and MTP range of motion. That is also contributing to the foot ulcer, and it end up the effect on the gait and function. About the fat pads, also there's some studies that there's a thinning and also distal displacement of the fat pads. And they found that the diabetes had statistically significant thinner fat pads at the heel and first and second metatarsal heads comparing to the control group. So all these together can cause also foot deformity and can cause can increases the risk of the foot ulcers, and then affect the gait, and also make it contractures, and also affect the gait and function in the diabetes patients. So more about the ulcers and also the arthropathy. There is a famous deformity causes the Charcot neuropathy, and also or Charcot foot. That is a common type of deformity that occurs in patients with the peripheral neuropathy, and so that's a process of bone subluxation and dislocation with the bone destruction and new bone formation. Typically, it has a deformity is a midfoot collapse, and commonly it's described as a rocker bottom foot. And these deformities lead to the increasing of the risk of ulceration. Factors that are contributing to the Charcot foot is the sensory loss and inappropriate inflammation in the foot. And so here you can see in the figure, there is a subluxation of the midfoot bones, and also there is a twisted first metatarsal bone, and also bone fragmentation here, and then causes the Charcot foot. That also increases the plantar pressure, and also the risk of ulceration again as well. So more about the next topic is about the diabetes gait deviations and the reflections of that. So let's look at what are the diabetes gait deviations. So DPN can cause a high stepping, or they can call it a feet slapping gait. So here you can see in the video that neuropathy can cause a feet slapping gait, and that is due to sensory and motor impairments. These are compensating mechanisms And the purpose of that is aimed at maintaining balance and preventing falls. But it can also increase the risk of injury and reduce mobility. So here in the video, you saw that there are key gait alterations in diabetic neuropathy. One of that is lower gait velocity. So individuals with the DPN tend to walk more slowly, and that's a protective strategy to reduce the instability and the risk of falling, because there is an impairment of the proprioception and also muscle strength. So that lower gait velocity is a protective strategy for these patients. The other gait deviation is shorter stride length. So stride length is reduced. And this is likely due to decreased motor control in these patients and also fear of falling. So this also contributes to a shuffling gait pattern that you saw in the video. Longer stride time and stance time. So here you saw in the video also that the patients spend more time in each stride and in the stance phase. That's the time that the foot is in contact with the ground. And that is reflecting the cautious walking and the difficulty of transitioning between the steps. So that's another deviation. The other one is the wider base of support that you can note in the video. That helps compensate for the balance deficits. And that is very common to observe in the patients with the sensory loss in the feet. And that's aimed for the increase of the stability. You can see also the higher knee lift and forceful foot strike. This is also for compensating for the reduced plantar sensation. So patients may lift their knees higher and slam their feet onto the ground. That is for the generating sensory feedback through some vibration effects from the ground. So that's a form of sensory substitution. The other thing is all of these gait changes that's exacerbate in the low light condition. So they worsens in the dark, and that is because of the loss of the visual cues. And so because visual system helps them to compensate for the impaired perception, and so the lack of a light can exacerbate all of these deviations, and so can finally lead to like an increasing of the body postural sway and also higher risk of the falling. So these gait changes not only increases the risk of falling and foot ulcers, but also they contribute to the reduced mobility and also the quality of the life. So basically, the major reflections are higher risk of falling and higher risk of ulcerations, but overall, it changes the quality of life and also mobility of the patient. So that means that interventions are all necessitated for these patients. So first reflection is focused on the low stability. So there is a higher risk of falling during walking. So again, like people with diabetes neuropathy, they are at far greater risk of falling compared to the people with intact sensation. And most of the falls occur during locomotion, during walking. And so that is suggesting that these patients may have difficulty maintaining their dynamic stability during walking. So relatively, they have a reduced walking speed, cadence, and step length that I have reviewed in the previous slide. They have also fewer acceleration patterns, and that is also correlated with the falling experiences. They have also, again, increased magnitude of the stride to stride variability and decreased magnitude of the local stability, and these are all associated with this disease. So again, based on the studies, gait speed is positively correlated with the it's correlated with the survival advantage, and since it's lower, that means there is a correlation with the with the survival in these patients because they are at the higher risk of the like a falling, and there is a reduced dynamic stability. So the higher risk of falling in some studies showed that this is correlated with the greater deviations of their body center of mass from center of pressure. Just to remind you about the stability control. So all the time, the center of pressure in our body follows the center of mass and bring it into the margins of the stability. But in the patients with the diabetes neuropathy, because of the effects and impairments into sensor system, that is suggesting the lack of that sensor feedback plays a pivotal role here. And that means that there is an impairment in correlation and relationship between body center of pressure and body center of mass. So the body center of mass cannot be deviated back within the margins of stability or the base of support of our body, and that is all because of the impaired sensation. So we can study, I mean, in studies, they can see like there are some unintended irregularities in the trajectory of the body center of mass from the center of pressure. And so that is also very prominent during the staircase walking and also during the level walking. That means that the body cannot smooth the unintended irregularities or the deviations or the variations that is happening during the unperturbed movement. So there is a lot of irregularities, a lot of variation in the trajectories of their body center of mass and center of pressure. And that is showing the instability and higher risk of falling in the diabetes patient. More about the stability center of pressure excursion can also show that. So there's a study that investigated and also did compare the diabetes neuropathy patients with the history of also ulceration with the control group and only with the diabetes group. So what they found was a decreased medial lateral and also longitudinal COP excursion. Here you can see also in the figure that there is a decreased excursion of the COP, especially in the patients with the history of the ulceration and also the longitudinal center of pressure excursion. That means that there is a longer loading time for these patients during the stance phase. And that is limiting the dynamic stability of the patients during the walking. Here also you can see in the other figures that this one is excursion of the COP along the longitudinal axis, and it's significantly lower in the patients with the history of the ulceration. And you can see the maximum COP excursion also along the medial lateral axis is significantly decreasing, and it's very much significantly different than the control group in the patients with the history of falling. These are all reflecting the effect of the diabetes neuropathy on the stability. So reflections of those factors that are the neuropathy on the higher risk is one of them is the higher risk of ulceration. So there are some studies on the plantar pressure. So plantar pressures are elevated, especially the peak plantar pressure are elevated in some areas of the foot in the patients with the DPN, with the diabetes peripheral neuropathy. And that is the compensatory musculoskeletal mechanism. And that is for compensating for their sensory deficits. So that is alteration, that is compensatory mechanism. That also can be due to the atrophy of the small muscles in the foot and also leading to loss of support surface and increases in the a pressure underneath the bony prominence. So atrophy of the small muscles, deficits in the sensory feedback, they're all contributing. So it can be both compensatory mechanism and also the because of the impairment in the muscle strength, the intrinsic muscle strength. So that is leading to the loss of the support surface. And you can see in the figure that there are some areas like underneath the MTP and also in the sole of the foot that is their experiences, there is a change and also significant increases in the peak plantar pressure, mainly at the midfoot and the forefoot, compared with the patients without the diabetes peripheral neuropathy. There is a increase of the peak plantar pressure. So other factors also have been identified to cause a raise in the plantar pressure. One of them is the development of the hallux valgus and hallux rigidus deformities in these patients. And they both cause increased pressure in the medial and also medial forefoot. And also although there are some foot atrophy, but some of those are some other factors can be also contribute to the increase of the plantar pressure. High body mass index also in a lot of patients with diabetes also is a contributing factors. And that is mainly increases the plantar pressure in the lateral forefoot. And also the higher peak plantar pressure is a key risk factor in the development of the foot ulcers. And so that changes also in the soft tissue thickness that I talked about in previous slides. That is initially a decreasing, and then later in the later stages of the neuropathy, it increases the thickness. So these are also contributing to the risk of the ulceration in the diabetes patient. So mainly the high plantar pressure is the key risk factor in the development of the foot ulcers. So that is basically something that is showing the risk of the ulceration in the patients with diabetes peripheral neuropathy. So other factors are reduced muscle strength. So I talked a little bit about the smaller muscle mass in the intrinsic muscles, but basically there is a sarcopenia, and it's an atrophy in the muscles, the leg muscles, and it's progressive loss of function, and that is associated with the hyperglycemia. And hyperglycemia accelerates this loss of the muscle size and also the strength. So some studies show that a muscle strength and then muscle strength have been reduced, and that is very important for producing enough power and making plantar flexor torque, and that is reduced. And also that is also causes the reflected in the reduced ankle and knee maximal isokinetic muscle strength as well. So basically that sarcopenia can be reflected in the muscle strength studied by the reduced ankle and knee maximal isokinetic muscle strength. And also muscle atrophy is also very pronounced in the diabetes patients, especially in the intrinsic muscles, in the distal muscles. Here you see that in the figure. That's a MRI image through the proximal part of the lower leg and also the midfoot region in the neuropathic diabetes patient. That is before the study and also in the follow-up study. So you can see the muscle mass that is decreasing, comparing A to B and C to D in the midfoot and also in the lower extremity. And it's progressing steadily, and it can go to the higher levels of the lower limbs, and that is very related to the severity of the neuropathy. So there are some effects of the neuropathy on the muscle contraction. So some studies showed that there is a slower contractile properties and specifically slower dorsiflexion contractile properties, and that is studied in both evoked and voluntary contractions. And that is also may contribute to reduced muscle quality and also higher fatigability in the patients with diabetes peripheral neuropathy. So there is a less endurance also in the diabetes patients. And that is again back to pathophysiology because of the decreased metabolic capacity, atrophy of the muscles, switching to more glycolytic fiber types happen in the diabetes patients, and also decreased capillarization. So these are all contributing factors that affect the contractile properties of the muscle as well. Increases the fatigability, less endurance in the muscles, and also slower speed of contraction, especially in the dorsiflexors. So you may see some drop foot in some patients during the gait, and so that should be like a work during the rehabilitation. So more about the gait kinematics and kinetics. So going into more measurements of the kinematics and kinetics, that is basically like based on a lot of studies and studying the range of motion during gait. So basically, the aim of this section is to identify the specific differences in lower limb kinematics between patients with diabetes, peripheral neuropathy, and non-diabetic patients. So studying like what is happening in the kinematics, and that is contributing to the gait deviations. So basically, the range of motion at the joints is altered in the diabetes, and they have a reduced motion. Here you can see in the ankle, here the ankle dorsiflexors and plantar flexor ranges. And so that is the stance phase, and that is a reduced range of motion here at the ankle for both dorsiflexion and plantar flexion. In the knee joint also, you can see there is a reduced range of motion in the stance phases, specifically at the knee joint. And also for the hip flexion, that is also, there is a change in the range of motion, but comparing to the limitation here, some studies showed like a higher range of motion. And so this reduction in the ankle and knee is very prominent, and the glycation of the collagen, that is particularly contributing to the limited range of motion in the knee and also the ankle. In the hip, so there is a increased hip and knee flexion. Here you can see that here in the early stance, and also that there is an increased range of motion in the late stage of the gait in the dorsiflexor muscle. So if you can compare these two, to think about there is a higher range of motion in the ankle in the later stages of the gait, and also higher range of motion in the early stages of the hip movement. So that is telling us there is an increased triceps suture, the calf muscles stretch in the terminal stance. And the purpose of that is increasing the proprioception or storing some energy for the propagating to the next stem. So that is happening here in the dorsiflexors and plantar flexors here by increasing the range of motion here. So that's more like a stretching in the muscles, restoring some energy here. The hip flexors, basically that is telling us there is a shift of the movement from the ankle and the knee toward the hip range of motion. So there is a shift of their workload from the distals to proximal joints. And that's the reason that you can see like a changes in the range of motion at the hip can be like increased, or in some cases there like a not everyone found there is a decreases of the range of motion. That's the reason, because the workload from the ankle and knee shifted toward the proximal joints. Here more about the kinetics. Some studies worked on the ground reaction forces. So ground reaction forces is a gait marker, and that's associated with the gait stability. And that is a active force that reverses the falls of the center of mass beyond the base of support. So that's a reason that we study ground reaction forces. So here in the figure, the ground reaction force in the horizontal axis has been shown here. And you see like there is a decreases of the braking force and also propelling force here in the diabetes patient. So about the vertical ground reaction force at the initial contact and toe off. So there are some heterogeneity in the findings. Some studies reported the lower vertical ground reaction forces at the initial contact and toe off, but some studies showed a higher. And that heterogeneity was because of the differences in the, for example, studying the patients with the barefoot versus the shod condition, or small sample size, or this control over the speed of the walking. But overall, you can see like there is a reduced capacity for the control of the stability, because the ground reaction force, especially in the horizontal axis, medial lateral axis, declined, like it decreased. And that means that there is a less capacity of the body or active force to bring back the body center of mass within the base of support. So some studies that are also finding like there is a reduced vertical ground reaction force. They talked about also there is a less forward gait stability as well. So more about the kinetics, some studies work on the joint moments. There are not enough evidence supporting like the changes in the hip and knee moments, but some studies found there are some differences in the joint moments at the ankle joint. And so the peak plantar flexion moments are reduced in the patients with the DPN. So here you can see that. And they showed increased peak plantar flexion moment at the forefoot. So that means that there is an abnormal plantar pressure patterns. And that is all because of the that is associated with the redistribution of the joint moments in the diabetes peripheral neuropathy. And that is all linked to the reduced capacity to control the forward velocity at the heel strike. So that changes in the moments affect the distribution of the plantar pressure. And so some of the studies said that like that is because of the increased triceps sural stretch in the terminal stance, and that is increasing the proprioception or energy storage. Some people discuss that there is a prolonged hip extension moment in the mid stance, and that is compensating for a limited push off. So, but overall, because of the limitation in the joint range of motion at the ankle and knee, so that is there is a shift from the workload of the ankle and knee toward the hip joints and hip muscles. although like there are some controversies in these studies. So this is a figure that are kind of like a review about the gait differences in patients with diabetes. And you can see like in the heel contact and the loading response, because of the lack of the sensory afferent inputs, that leads like to delayed activations of some muscles. And so increased also skin hardness, contributing to the changes, mainly like lack of sensory afferent inputs, and also the limited joint mobility, muscle weakness. They're all like contributing to the changes of the gait in the mid stance, mainly in the terminal stance. So we can see like a wider base of support because of all these limitations. Again, like a limited joint mobility that affects the peak plantar pressure that is very prominent in the midfoot and also the forefoot. In the swing phase also, there is a high gait instability. And so there is a like a, because of the stiffness that modulate also the gait. So in general, the gait abnormalities in the diabetes peripheral neuropathy has multiple factors, and that involves the changes in the kinetics, kinematics, postural changes, muscle strength, and so that can contribute to the increases of the risk of falling, risk of ulceration, and also the mortality in the diabetes patient. So before talking about the rehabilitation piece of that, I'm going to go through the diabetes assessment guideline from the PT perspective. So before going into more specific areas like a gait or balance rehab, so PTs must perform a thorough initial assessment. That is for the purpose of understanding the patient's general health and how diabetes is affecting their physical condition. So this includes here the medical history, like a type of diabetes, complications, glycemic control, knowing the level of the hemoglobin, A1C, neuropathy, knowing about if there is any retinopathy, nephropathy, and also other comorbidities. Also, it's important to know about the functional mobilities and also activities of the daily life. That is telling us like assessing a patient about how independent they are in their performing their daily activities, knowing about the patient education. So that is like knowing about the like education of the patient about the food care, blood sugar control, healthy lifestyle, and the modifications. So that these are important to know at the initial assessment. Next is doing the foot assessments. So because the diabetic foot is like very common because of the neuropathy or ulceration or like a poor circulation, that is increasing the risk of ulcers and also the infection. So some part of our job, other than working on like a gait deviations, that is also include working on prevention and rehabilitation that is related to the only like the food, like a maybe reducing the risk of ulceration that affects their gait and function. So we need to assess the sensory, like the food, like do like comprehensive assessment, including like a sensory examination, like the test of the monofilaments, 10-gram monofilaments that is for assessing the sensory loss, using the vibration test tuning fork, and especially on the first metatarsal head. That's very important. Doing like a temperature assessment for like a temperature discrimination. Doing a motor examination, like a muscle assessment, muscle strength. Examining like an example of that is dorsiflexors, plantar flexors. Doing the range of motion assessment, especially in the ankle and the toes. Doing some vascular examination, like testing the pulses, like palpating the dorsal pedis and also the posterior tibial pulses, that's telling us like how is the like a vascular issues in the diabetes, or doing the capillary refill time. So that is telling us like how is the circulation. Also like we need to assess the food structure and skin integrity. So inspection of the food for the deformities like a Charcot bone, bunions or clawed toes, or skin changes, calluses, blisters, or ulcers. So these are all important as a part of like a food assessment before diving into the gait rehab. So we need to maybe like we need to put some of our rehab around only the food. Also, like knowing, like looking at the like a footwear is important. That is telling us like where are the pressure points and identifying the high pressure areas, and tells us like where is the, I mean, what is the risk of ulceration. If they also the footwear has a like a good comfort and also appropriateness for the patient. Assessing also the orthotics also very important, like a custom insoles or orthotics are very important, because that's telling us like if the pressure is well distributed, redistributed for the patient or not. So part of the assessment also like focus on the assessing the strength, endurance, and also the joint mobility, and also the circulation. So strength testing can include the MMT, focusing on the major lower limb muscles like a quadriceps, hamstring, calf muscles. We should do also functional strength tests like a sit-to-stand test, leg press, heel raises for the functional assessments. Joint range of motion is important because the neuropathy and also the effect of the glycosylation, that is definitely affect the range of motion. So doing a goniometric measurements, focusing on the ankle, knee, and hip joint is very important. That is telling us like what is the joint stiffness, or what are the contractures here, and if the patient has a limited mobility, or if there is a poor glycemic control, what is the effect of that on the joint stiffness. There are some also neuropathy related weaknesses, like specifically on the dorsiflexion and also plantar flexion strength. So looking for foot drop, that is very common, or other compensator gait patterns because of the muscle weakness. That is also very important. So looking for weaknesses that may require some like orthotics, for example, for helping like a foot drop. That is very important to know about the weaknesses. Knowing about the circulation edema, that is important. A lot of patients with diabetes have a peripheral artery disease, and so we should look for symptoms like a pain in the walking, or numbness, tingling, or coldness in the feet. Edema assessment is also very important in the leg for these patients. That is also telling us like about the mobility and also the comfort of the patients. Part of our assessment should go for the gait and balance. Gait analysis, starting by the observing the patient walking and looking for the speed and step length. So referring you back to the slide that I was talking about, the gait deviations. Speed of a gait is very important. Step length is also very important. That is, both of them are often reduced in the diabetic neuropathy. Compensatory strategy that I discussed, like the shift of the overload, the workload from the distals to the proximals is happening. So that means that like patients may walk with a wider stance for balance, different range of motion. Foot dragging also may happen as a compensatory strategies. We need to assess also the function, functional tests, like a gait specific also assessments, like a 6-minute walk test, and that is for assessing the functional endurance and also gait efficiency. Time get up and go would be another good test for assessing the mobility and fall risk. balance testing, like doing the Berg balance assessment scale is a very comprehensive assessment of both static and dynamic balance. So these are all like a kind of very much recommended to do as a part of our assessment before doing our interventions. Functional reach test, that is very important for stability and balance. Doing Romberg test, that is testing the proprioception, especially like this is very important for the patients with the sensory loss. It can go into like a single leg stance and also doing some fall risk assessment, like conducting some questionnaires about the fear of falling. But we need to document all of these before doing our gait intervention. More about the fall risk assessment. Tineti mobility assessment is a good one. Dynamic gait index is a good one for measurement of the walking ability in different environments. Doing some environmental and functional assessment, like evaluating the patient's home environment for the risk of falling. This is also important. Assessing the ADL and performance, like transferring from the different, transferring from the bed to the chair, or like climbing the stairs. These are also important ADL assessments. These are references for this section. Next section is about the rehabilitation of individuals with diabetes. So basically, the rehab for the diabetes patient is multidisciplinary care, and it needs a continuous monitoring. So it's very comprehensive, multidisciplinary approach in rehabilitation. And these strategies should tailor to the needs of the patient and address both physical and also psychological aspects of diabetes gait rehab. So remember, when I was talking about the factors, behavioral factors were contributing, like depression, other than the physical and the abnormalities. So these are all like factors that are contributing, and rehab should be multidisciplinary. Continuous monitoring is very important. So doing a regular reassessment is very important. So doing like assessment every 3 to 6 months are needed. So reassessing gait, balance, strength, foot health, that is very important for tracking the improvements or the changes. One part of their rehab is checking on the blood glucose monitoring. So we need to collaborate with the healthcare team to be sure like they are at the good level of the blood, like they are doing good with their blood glucose monitoring before and after exercises and throughout their day. The other piece of their rehab is adherence and motivation. Piece of our rehab is going to educating the patients and also encouraging to adhere to their exercise program. That is by like stressing there is a long-term benefits for adherence to the rehabilitation. And that means overall, again, this is a multidisciplinary care, and we need to collaborate with other professionals like the endocrinologists, if the patient has a poor glycemic control. So we need to collaborate with the endocrinologist. Podiatrists for the foot care and management of the ulcers and infection. That's also a very big piece of our rehabilitation. Working with the dietitian, so having a high BMI and like weight management issues, that's also affecting not only like the gait, and also increases the risk of ulceration, but also problem with the weight management affects also the glycemic control. So working with the dietitian about the nutritional guidance is also very important. So again, that's a multidisciplinary collaboration. So based on the ADA, the intervention for diabetes, again, it's multidisciplinary, focus on glycemic control, diet modification, physical activity, and rehabilitation. So here you see like a list of intervention types that are kind of like important, and also these are interventions that are very important for these patients. Some of them focus on anti-sedentary behavior, like having a goal setting, having a coaching, like access to the coaching, or like a diet modifications, working on the calorie restrictions, or emphasize on the nutrition control. But other exercises focus on aerobic exercise. So 150 minutes of physical activity per week. Uh, that's a level that is based on the ADA is recommended with the moderate intensity. And that can come with as a brisk walking, running, cycling, swimming, dancing. But the 150 minutes of the physical activity per week, that is very important for patients to keep it up. So resistance or strengthening exercises, that is also recommended by the ADA. And balance exercises, including the Gait rehab, these are very important. Like doing like a single leg balance exercises or Tai Chi are examples. I'm going to go through into more details about that. So key components here for the rehabilitation. Basically, the ADA focus on some low impact aerobic exercises, cardiovascular, 150 minutes of physical activity per week. This is with the medium intensity. Strength training and resistance exercises, doing balance training, like a balance boards, for example, and also doing a foot care education. So again, this is a multidisciplinary approach, combining lots of physical activity and exercises with the diet control, glycemic control, food care, and also education. And the adherence to that plan of care, keep patient motivated, is very important. And also continuous monitoring of the patient is very important for that. Some piece of our rehab is focusing on non-pharmacological pain management. So there are use of some passive modalities like a Thai massage, foot bath techniques, or static magnetic fields. These are proven to have a good, like a positive effect in pain management. Recent studies focus on the use of like spinal cord stimulation. So these are like surgically implanted in the epidural space and reduce the pain in the DPN. Or use of a TMS using a deep cortical stimulation that has been reported to have a short-term reduction in the perceived neuropathic pain in the people with DPN. But comparing like a conventional type of like a modalities or physical agents like infrared light or near infrared laser energy, TENS, or acupuncture treatments, they did not show like a superior effects to the sham group. But they're not consensus on all of these modalities among everyone. But basically, Thai massage, foot bath techniques, static magnetic fields, they are more like they showed some effects on pain management. So interventional studies about on the gait disorders. So basically, it's a multidisciplinary approach. So that means that there should be collaboration between physical therapists, podiatrists, orthotics, and also some diabetes specialists. These are very important. So the effective management of the gait deviations, like in the individuals with the DPN, necessitates a very comprehensive multidisciplinary approach. So there should be a collaboration between a healthcare team, and so then they are able to develop a personalized care plans based on the specific needs and also the limitations of each patient. So that means that there should be an integration of the expertise from various disciplines. And that is ensuring the holistic and a tailored approach for managing the gait and function in the diabetes peripheral neuropathy. So focuses of the gait interventions, some of them focuses on preventing the diabetes foot ulcers. So again, gait rehabilitation is not like separate from reducing the risk of the ulceration. So that means that there are some strategies that are focusing on gait, but they are more also focusing on reducing the risk of the ulceration, because all of the deformities, all of the changes in the peak plantar pressure, they're all contributing to the gait deviations. So some of the studies focuses on redistributing the plantar pressure, and they found it like contributing to the gait and function in the diabetes patient. So that means it's a key for addressing the detrimental effect of the gait disorders in people, focusing on preventing the foot ulcers. And they focus on the redistribution of the plantar pressure, and that is by recruiting the areas of the foot with the lower pressure, and redistribution looks at recruiting areas of the foot or lower leg that are not normally weight bearing, or that are normally like under lower pressure. So redistribute the pressure to those areas. And also redistribute the pressure across a wider areas. And that is reducing the peak pressure in only one area, that is typically in the forefoot and midfoot for the diabetes. And that can be done by application of the various insoles, braces, cast, or the rigid soles. Depends on where the clinician wishes to transfer the pressure. So a total, for example, contact casts are like very effective methods for offloading the plantar pressure in the presence of an ulcer, and that aids healing. So redistribution of the peak plantar pressure. So other methods, so proper footwear selection, that is also crucial for, that's a very important intervention. So appropriate footwear and orthotic interventions in managing the gait deviations. So there are some custom orthotic devices for redistributing the pressure and also supporting for the arches. So these are all some footwears or orthotics. Use of the insoles for the offloading the high pressure areas. And so the use of also some braces that basically aids the doing like a dorsiflexion, because foot drop is very common because of the effect on the contractile properties of the dorsiflexors. So helping the dorsiflexors are very important and affects the gait very much. Use of the AFOs, that is also addressing the foot drop. Also, it can enhances the overall stability. Having a total contact cast or insoles, that's a very effective one. That is for the reducing the pressure at the metatarsophalangeal, the MTP. And so overall, I mean, using the orthotics and footwear is a big a component of the gait rehabilitation. It's a part of our intervention. Some methods are also recommended, like a backward walking therapy. This is a specific for time that there is a high plantar pressure in the patient, and there is a high risk of ulcer, or there is an active ulcer. And that is focusing on the reducing mainly the peak plantar pressure in the forefoot. and that is also like increasing the a balance, improving the balanceability and also the muscle strength. That's one strategy to use, the backward walking therapy. That has been studied and is recommended. Again, focusing on the joint mobility. So gait deviations in some diabetes patients may come because of the plantar fasciitis, for example, or the limited range of motion in the ankle and knee. So manual therapy has been shown to have extensive benefits for that, like a passive joint mobilization. Manual therapy, again, for improving the range of motion, alleviating the pain, and so these are very important. There's also importance of the mild stretching, so incorporating some regular stretching, and that is also should be part of the program, improving the flexibility and also preventing the stiffness. Again, strength training is also recommended very much by the ADA. That is very important for improving the muscle support around the joints, increasing the stability, and also focusing on that also helped for the first focus, that is for the doing the gait interventions through the reducing the risk of ulceration and minimizing the stress on some compromised joints, mainly MTP and also the ankle joint. Some studies focus on reducing the risks of the falling, again, by the use of the assistive devices. That is very helpful in the severe cases of the gait deviations. In combination of these assistive devices can include the ankle foot orthotics, AFOs, and canes also. They are both recommended to enhance the stability and mobility, especially as I said, in the severe cases, and that mitigates the risk of falling. Especially the AFOs, they are designed to provide support and facilitate the dorsiflexion, and so that counteracts the foot drop. They can come in various forms, like a prefabricated or custom made, but they should meet the needs of the individuals. Canes can be another offer for improving the stability and mobility, and that is reducing the risks of the falling as well. Some studies focus on the reducing the risk of falls through various type of the exercises. So combining the aerobic with resistance, stretching, and also the functional exercises. So again, the exercise training is an indispensable component of the gait deviation management, but it should come with the use of the gait management. So it should come with the management of also the other contributing factors, not only the exercise training, addressing the risk of foot ulcers, addressing the stability and falling with the use of assistive devices. So some studies focus on gait training, strength building exercises, and balance enhancement drills. This is the list of exercises that are combined in one study, brisk walking, swimming, stationary bike, elliptical trainer. So resistance exercises, this is important for bringing back the muscle strength, especially to the legs, like doing a leg extension, chest press, or seated row. Functional training has been a part of their intervention, and that is for example, improving the balance, like a dynamic balance, sit to stand, for example, stair climbing. We as a physical therapist, we can guide our patients through a balance exercises, addressing the proprioception deficits, and an overall stability. Stretching and functional exercises, that addresses the limited joint mobility, again, affects the range of motion and also the compensatory mechanisms, like standing calf stretch, plantar fascia stretch, seated hamstring stretch, or chair squats or calf raises. These are all like they have proven effects on the mobility and also on the range of motion and also on the balance as well. And also on the complications of the diabetes. Typical gait intervention, based on some studies, started by like 5 minutes warm up, 40 minutes of maybe like circuit training, combining the balance and walking tasks, like a stance on heel toes, tandem stance, one-legged stance, different kinds of walking, functional strength, and also the endurance exercises, like sit to stand, walking up and down, slope, stair climbing, mini hops. They're all recommended. So there are plenty of studies focused on different regimes for combining these effects. Mainly the complexity of the task should be progressively increased. So changing from, for example, stable to unstable surfaces, or increasing the step height, for example, or combining it with some interactive games, like an obstacle race. And that has been also very important. So short feedback session, that is improving the motivation and adherence of the patients, like doing some individual home exercises in the last 5 minutes of a session. That has a proven effects on the gait of patients. Some studies focus on the reducing the risk of falls, like through the Tai Chi and yoga. So Tai Chi, that is other than stability effect or postural control, can affect the quality of life and also improve the glucose control as well. Yoga can improve the static and dynamic balance performance, lower extremity muscle strength. It has also like a proven record on reducing the fear of falling as well. So the cognitive aspects of the factors contributing to the gait deviations. So these two are not only on the physical aspects, but also on the cognitive aspects as well. There is a study focused on sensory motor training. They call it sensory motor training, and they focus on only enhancing their perception and balance. So they try to heighten the awareness of their foot position, weight distribution during the gait, facilitating the stability and also the gait mechanics. And here you can see the type of exercises they did. For example, standing on unstable surfaces, performing some single leg balance exercises, combining that with the weight shifting movements. But overall, they're focusing on enhancing proprioception and balance to improve the gait. So there's another, like other studies focus on ankle, like they call foot ankle therapeutic exercise. The main goals of those studies were increasing the flexibility of lower extremity function, focusing on the strengthening of only the intrinsic and extrinsic foot muscles. And then in the later stages, work on the autonomy for the daily living activities. So combining that with some daily living activities. So they started by warming exercises, like stretching exercises, massage of the muscles, and then they moved on to working on intrinsic muscle exercises, like toe alternate, pick up an object, working only on the intrinsic muscles, strength, like a toe flexion, plantar arc raising, and then work on the ankle exercises, extrinsic muscles, like climbing on the tip, like a tip of a feet, kick the floor, tighten the ball. And then in the later stages, they move on to the functional exercises, like walking across the steps, step forward and backward. So focusing on the function. And they called it the foot ankle trapeze exercise model for the improvement of the gait. Some studies focus on the combination of the effect of use of whole body vibration with the balanced exercise program. So whole body vibration has some effects on the diabetes patients. That is increases the oxygen consumption, increases the energy expenditure. That affects the whole body vibration, can affects the insulin sensitivity through some hormonal changes. So affects the blood glucose at some point, affect also the bone density, like the stimulating the muscle contraction, effect on the trabecular structure of the bones, affecting the cartilage. So whole body vibration has all of these effects, and they combine it with the effects of the exercise training. So they have been through some warm-up exercises, including stretching, flexibility exercises, move through like a use of like a balance training, static, dynamic exercises on the whole body vibration device. And then they have done it progressively. And then they had a cool down activities. And they found the benefits of the balance exercises, muscle strengthening, and also the effects on the H1, hemoglobin A1C as well, is other than the effects on the balance and muscle strength. The last group of studies focus on the doing some motor learning approaches. So that's what I also did as a part of it, focus on the task-oriented training, using motor training, motor learning principles. The idea behind that was the relearning of some functional activities can promote the timing and coordination of the lower extremity movements, and especially on the focusing on the timing and coordination of the foot and ankle. So I used some goal-directed practices with some repetitions, using guidance and feedback in variable context. And I made it progressively difficult. So you can see in the figure, this is showing like a characteristics of the task-oriented approach, focusing on the motor relearning, basically. Starting by like flexibility exercises, moving to the stepping, making it progressively hard, starting by simple walking, making it more complicated on various contexts, and then combining it with the upper extremity exercises, so make it progressively difficult, and then work on the pace of walking on the treadmill. So that's something like a focus on task-oriented training. And then I found a really good results, in the vertical ground reaction forces. There was an increase of the second maxima and the reduces of the minimum vertical force. I also found the increase of the propulsive force, ground reaction force in the medial lateral direction. And they're all they're all together indicating there is a better stability. So remember, like a ground reaction force is a force that directing the body center of mass back into the within the body center of within the body base of support. So that means a patient in like a the training improved the gait performance using the motor learning principles. I also found the confidence to their walking, also the function, the time get up and go also improved, and also the EMG results supported the ground reaction force result to some extent. So typically, the diabetes patients have a the onset of the activation of the soleus and gastrocs are earlier. What I found was by doing a task-oriented approach, there is a delayed onset activation of the soleus and gastroc. So that means that overall there is an improvement of the performance. And so patient had a better foot clearance with the stronger push-off from the floor after the training. So task-oriented approach is another approach for motor learning, and also focusing on the gait, like intervention for the patients with the diabetes. These are references for this section. Last topic for today is about the key applications of AI in the diabetes rehab. So I'm integrating that piece because of the interest coming around the AI, and mainly for diabetes patients, mainly for the gait and also gait rehab and also fall prevention. AI can help with the adherence of the patients and monitoring. So that's a big piece of the rehab in the diabetes patients. Technically, in the diabetes care, AI, like including the machine learning, deep learning, neural networks, they're all being integrated into the diabetes care. Could be used, for example, for clinical decision making. Basically, remote monitoring is a big piece of that, and also improving the adherence, the monitoring piece. And also empower the patients with the self-management tools. So that's the power of AI. And also favoring the rehabilitation because of we have a tool for monitoring the patients. So it can support the physical activity and also the rehabilitation, fall prevention, and which are very critical for managing and preventing the complications of the diabetes. So gait and walking is one piece that is interacting and intercalated with other pieces of rehab. And big piece of that is the monitoring. So all part of the AI in different levels. So they are all integrated and helps the healthcare providers for clinical decision making. That's one part of it. And also the self-management. That's another part of it. So, AI tools for diabetes care mainly focus on physical activity and nutrition management, glycemic control, and also I saw some also like some kind of like AI techs that focus on integrating the like a healthcare for the diabetes because of it has a comprehensive nature. So they are trying to connect the providers to each other. I don't know how successful they are, but they are talking about it. So in the like for the physical activity and exercise optimization, some devices like AI has been part of our smartwatches, fitness bands, and it has been used in the diabetes. They are able to track, like, for example, the step counts, walking duration, intensity of the physical activity, and AI is part of that. So these are more at the like a wearable technologies. And they can provide, for example, the real-time feedback, some personalized recommendation through the app, or detecting some patterns of the physical activity behavior and suggest some modifications to that. So these are like what I saw as like AI-driven tools for tracking the physical activity. And again, this is essential because part of like a gait rehabilitation ties to the glycemic control or weight management. So, and it's a part of also ADA recommendation that physical activity for the cardiovascular system is like something that very important, should be part of our intervention and rehab. Some other technologies like mobile apps or some digital platforms, like they use the computer vision technology or some other wearable also technologies. So these are for supporting, for personalizing the exercise programs. So think about the balance exercises. So I'm working with a company that focuses on the computer vision AI, and that is very helpful for like customizing the balance program for the patients with with diabetes. There are also like similar platforms. Some of them use the wearable technologies, but most of them are able to do a customize the plan of the care, the exercise programs, and part of it is focused on the gait and also the balance rehab. It can also analyze the AI can also analyze the patient data and recommend exercises based on the food intakes. That's also one other piece of working with AI in the diabetes care. Part of it is also focused on the balance and strength or cardiovascular endurance. So it can be personalized through that part as well, both using wearable technologies and also the computer vision. Real-time monitoring, that's also very important, basically for monitoring the blood glucose. Like AI has been used for the continuous glucose monitoring devices. So that is for optimizing also AI has been used for optimizing the effectiveness of the workout session. So apps can do a real-time monitoring and adjusting some exercise intensity based on the needs of the patient. So I found a study they do both diet and also exercise program, use of AI-driven coaching. And then after 12 weeks of a study, they found 28% of the participants achieved the hemoglobin A1C, which is a very important biomarkers of the glycemic control, below 6.5%. And so also there is AI integrated for the medication control and use of medications, or for improving the glycemic control. That has also improved 57% in the medication use or control of that. Again, more about the impact of AI on the personalized exercise program. Basically, the use of a computer vision AI that is tracking the body movement, and that can reduces also the risk of injuries during the exercises. So think about the diabetes patients are able to do the exercises in front of the webcam of their system, like their tablet, their cell phone, and they can be tracked. So that means there is a reduced incidence of exercise-related injuries because of the tracking of that, and that can be reported to their healthcare provider, HEMSCap provider. That can also increases the adherence. So adherence is a big issue in the diabetes. Gait rehab intervention or PT rehabilitation and PT interventions. So that also enhances the patient safety also, because the exercises are personalized based on the needs. So think about a patient with the plantar fasciitis. So the exercises are basically designed for not only the gait and balance, but also for the plantar fasciitis that she has. And so it can include the history of the injury into it. It can also increases the patient confidence. So part of the use of AI is for improving the rehab program by increasing the confidence of the patients. So motivation, the cognitive part of it. And so higher engagement of the patient is one other piece of that by the use of AI. So another piece of AI is basically very much focused in some studies in gait rehabilitation and fall prevention. So there are some AI algorithms that are basically focused on use of technologies for real-time gait analysis, like identifying the fall risk. I'm sure everyone has kind of experienced that with the smartphones. There are some other also technologies that are good for tracking the gait deviations in real time and giving some information and also feedback about the potential risk of falling. But think about like focusing on the gait rehab and fall prevention enables the healthcare providers to have a better, like a timely interventions, and also the personalized rehab strategies, because they're all like a tailored together, including the real-time feedback, including the tracking, including the personalized rehab strategies, all based on the needs of a patient. And so some studies focus on only like a fall prevention very much. I found a study like they integrated AI in the fall prevention, not necessarily in the diabetes patient, but it was for a group of people with the poor balance control, including diabetes, and they found like a 28% reduction in the fall incidences. And so overall, also like there are some studies also like significantly improve the patient outcome and reduces the risk of like a serious injury. One piece of important part of the AI is again like remote monitoring, because it's a chronic disease. Not every patient is capable of coming to the clinics for some years. So that means the AI is able to enhance the patient engagement, give them an opportunity to benefit from the healthcare system by some continuous interaction. So it's motivating the diabetes patients to do their plan of care, balance and gait exercises continuously over like by the remote monitoring. Having a real-time health insights, like a real-time feedback, is also very important, is a piece of AI that is very important for the remote monitoring. Again, effect of AI is like there are in some studies for the glycemic control, physical activity, adherence rate that is increases by the use of AI monitoring to the rehab programs, and also for the nutrition management is a part of like a remote monitoring. So that comprehensive model, the multidisciplinary, can be done with the use of AI systems. There's some apps that can take the image of the food and then, combine it like with the calorie reports and help the diabetes to control their calorie, weight management, and also like prescribing exercises. Again, the impact of AI on the engagement in one study, I found like a 20% higher adherence to the rehab, and that's combined with that physical activity combined with the glycemic control. So there was a improvement in the hemoglobin A1C by 0.51%, which is like an incredible amount in the diabetes patients. So basically, it contributes to better long-term health. So back to the pivotal PT. So this is a platform. I'm hopeful to use it for the tracking patients in my research, for tracking movement with the computer vision AI, with some personalized feedback and exercise plan to look at the adherence of the diabetes patients to their like a task-oriented balance exercises that I found interesting. So I'm open to hear from the audiences about potentials they may have, like, or like potentials for the collaboration on that piece. The other thing is I'm doing with that Pivotal PT platform is educating the physical therapy students about the use of AI for patient monitoring overall, not specifically in diabetes. That is ties to look at the Gen AI also as a part of it for the documentation, and also the computer vision AI. So they are both together enhances their clinical reasoning and also for the monitoring. I'm also open to hear from the audiences if there is any like a open collaboration for integrating, because we are at the SMU trying to integrate that AI integration to their curriculum. And so that's another hope. So I would be open to hear from the audiences. So these are all references that was for the AI piece of the lecture. So thank you and for your listening. And I'm open to your questions.
Thank you very much. Early on, we had someone ask if you could discuss why does the first metatarsal rotate?
And let me turn up my volume quickly. I didn't hear your question.
Oh, very
Okay.
good.
Okay.
Yes. Why does the first metatarsal rotate
In
in gait?
uh-huh. So that pressure, the plantar pressures, especially like when it's developing deformities, can be conducted toward the forefoot, and the rotation of that basically happens because of the concentration of the peak plantar pressures under the MTP joints and toward the medial part of the foot. Think about also some subluxations that I showed in the Charcot foot deformity. That also affects the medial arches, and that changes the biomechanics of the foot also. Foot. So that means um, rotation of the rotation is also a part of it because of the changes in the biomechanics of the medial arches. So it's more like a compensatory mechanism, like the progression of the hallux valgus also is a part of a Charcot foot, and that's because of the arches are not functioning well. So there are some contractures in the intrinsic muscles, and because of the distribution of the pressure happens.
Great. Thank you very much.
Mhm.
Another question that came in was not everybody is familiar with the foot bath techniques or static magnetic fields. Could you describe those, please?
I may not be a good one for going into details about that. And feedback techniques, I think from the study that I included in here was hot cold therapy for the food. So that's basically affect the vascular system, doing like a hot and cold baths. So that means a constriction of the vascular system followed by the dilation. That's what I remember that, and I think it has like a 15 minutes of the protocol starting by the I think hot bath. I'm not sure about it. And then 2 minutes in one, and then 1 minute in the other, like a cold, and then switching. There might be other studies that doing it differently, but I think that's the one that noted in the study. About the magnetic field, yeah, I should go into the details about that. Yeah, so I do recommend, I can look up the research and then get into that research paper and then get more details about that. But yeah, on top of my mind, I don't remember that.
It's okay there. Thank you very much. Will you be sharing the references or the entire PowerPoint with us at the end of the evening?
I'm hesitant to do that, but if there is any specific question that need a reference, I can add up, especially about those modalities. I can pass the information.
And can I provide them with your email address at Samuel Merritt University?
Yeah, definitely, for sure.
Okay, very good. I'll put it in the chat. Another area that we're not all familiar with is the whole body vibration intervention. Can you discuss that?
Yeah, sure. So whole body vibration, I don't know, it's shaking whole body on a flat device. There are a lot of like a whole body, there are a lot of studies working on the use of whole body vibration on the bone mineral density, basically strength training, also balance control. So that's basically standing on a vibrating device that is coming with different frequencies. I think the lower frequencies are better for this, like combining with the stretching exercises. Higher frequencies are better for improving the power and force. And so combining the whole body vibration, and whole body vibration has some effects on the hormonal control. Basically, it affects the like insulin sensitivity. It has a vascular effect. I don't know if you, I mean, some people have used those like a vibrating machines, like a hand machines. And when you're taking it off, you see some redness underneath the place of like the placement of the machine. So that's a vascular effect of using vibration. So think about that happens through the machine, like a whole body vibration machine, and that affects on the vascular system. So help the like a VEGF is the factor that can be released because of the whole body vibration, and that has a effect on the regenerating the vascular vessels. The effect on the insulin sensitivity, glycemic control also is a part of whole body vibration. So that is study combined the whole body vibration with the physical activity, and they found a positive response.
Very good. If Ruth has any follow-up questions about that, then please enter it in the chat or turn on your video and unmute yourself and we can speak to you directly. The next question is, do you have any evidence that interventions can alter the progressive course of atrophy in the intrinsics?
You mean, you said atrophy?
Atrophy, yes.
I don't remember on top of my mind. So yeah, I don't remember any study focusing on the cross section of the intrinsic muscles, like doing the strengthening exercises, basically. But the study that actually focused on the foot ankle therapeutic exercise was trying to do so. Maybe not returning the whole strength of the intrinsic muscles back, but basically stop the progression of losing the intrinsic muscles mass and strength over time. A lot of that is also what I found was tied to doing regular exercises and also focusing on foot and ankle exercises very much. But I don't remember any exercise that only focus. I mean, it might be because of my limited knowledge about that. But basically, all these exercises that focus on the gait intervention, they are trying to stop the loss of strength, not only in the intrinsic muscles, but basically in also extrinsic muscles, lower limb muscles.
Okay, thank you. You provided a list of shoes earlier. So we'd like to know, what about high foam shoes like on cloud runners with a custom orthotic versus the shoes you listed? Any thoughts or ideas, preferences?
So based on what I found, the custom made, because of redistributing the plantar pressure, like, and there's some technologies that are scanning the foot and assessing the plantar pressures, and they try to, put the pressure underneath the areas that are not bearing, on the divided areas. those have a proven record, but I don't remember any studies that are comparing these two, basically. Yeah, high foam can also do a redistribution of the pressures, but I don't know that. Yeah, I can look up.
I just wondered because a lot of the shoes that you showed before have a lot of effort to put in, and I just don't think this population is willing to go through that on a day-to-day basis per se, but they might be willing to slip on like a high foam shoe that maybe looks better and is easier to put on and may have somewhat of a benefit.
Yeah, I agree with you. They're hard to put on the patients very much. High foam would be another option, but I don't remember any study comparing these two or comparing the effects of these two. There are plenty of studies on the orthotics food for the footwears and also the different type of shoes. But overall, like what I presented, I have some kind of like effects on the gait, basically. But that doesn't mean like other shoes, like a high foam, would not have effect, or maybe like it's easier to put it on the patients. Next question.
Thank you, Eric. Okay, Dr. Robles, did you want to come on and ask, or do you want me to read your question? All right, let's see. He says that in the clinic, he's observed that patients with peripheral neuropathy often tend to lose their balance backward and appear to bear more weight on their rear foot. However, during kinematic testing, you've shown it's been noted that foot pressure is primarily on the mid forefoot. Could this discrepancy be related to differences between static posture and dynamic gait?
I have seen some patients that have rare foot issues. It could be because of the lack of strength in different muscles. So what I have shown was typically like forefoot and underneath the soles, they have a higher peak plantar pressure. But I have seen also some patients with the heel ulcers and then having more pressure underneath their heels. But overall, like I showed like a figure about that, like the figure is showing like there is a problem with the distribution of the plantar pressures on different areas of the foot, but that was like the closer to the forefoot and the metatarsals, it was significantly different. It could be because of the differences in the muscle strengths. And also it could be because of the compensatory mechanisms the patients with the diabetes neuropathy do, like they are pushing off harder because of the providing more momentum and for progression toward the next step. So it's kind of like a compensatory mechanism during the dynamic gait, and that increases the pressure underneath those areas. If someone is having a limited mobility in the joints, that's what I have seen have, like they're more prone to have heel ulcers and a higher plantar pressures under the heels. But most of the patients are going through the compensatory like mechanisms, and this is basically because of compensating for the sensory deficits and developing the wounds, developing the ulcers underneath the forefoot and midfoot. And the other reason is forefoot and midfoot, because of the development of the deformities, the Charcot foot, that is basically subluxation in the foot structure, in the midfoot bones, and that's another reason. But limited mobility would cause a patient to start like the initial contact and a lot of pressure underneath the heels as well. That could be another reason too.
And Teresa Ragland is with us tonight. She has a couple questions for you.
Hello. Okay, thanks. I'm fascinated with modalities. So my question was back towards that as well. I wanted to confirm that TENS was not useful and infrared too, because I can understand TENS, but
Mhm.
I understood that as being something that could help with even wound care and healing for tissue healing.
Yeah, what I found in the most of the studies, they're not like a consensus on the use of physical agents. There are a lot of studies says the effect of the TENS or the infrared light is not above the sham group. Again, there's not a consensus on that. Massage, Thai massage, foot bath massage, they're kind of like have a proven record of effects on the improvement of the vascularity also, and also improving the neuropathy. But about the physical agents, there are a lot of discussions, a lot of discussions.
Then magnetic fields, I was thinking diathermy would be a magnetic field, electromagnetic field. So maybe
Mhm.
that's something that you could see coming back for our future, because I feel like it's not being used anymore anywhere.
I should dig into that study and see like what was the purpose of that they have used. Diathermy is not a good one for using for the diabetes patients because it has a lot of like a heat that is going internal, and because of the bad like poor circulations in the diabetes, I do not recommend using the diathermy. Maybe they have been using the
And not,
magnetic fields, yeah, with other devices, but I have to dig into that. But I don't recommend diathermy. It's not a good choice.
well, I
They
know
have,
there's a non-thermal way of diathermy too, but
maybe, yeah, maybe, yeah,
yeah,
maybe.
I'm fascinated with modalities, so thank you so
Maybe,
much.
yeah, maybe like for the gait interventions, I saw a lot of positive responses in research about using whole body vibration and also the doing the balance and gait exercises on top of that. So combining the effects of these two.
So I
But
that kind of whole body vibration treatment already for bone density.
yeah,
It's really fun. I highly
Very good. Well, I think we've covered all the questions that have come in this evening. I'd like to thank you, Dr. Salsabili, for joining us. This is the second time this year you've been with us, and so I'd like to welcome you to California, and I do appreciate your contributions. Webinar Wednesday continues on July 30th when we discuss risk management, IT security, ethics, and more. So if you're still looking for 2 hours of laws, ethics, or regulations for your licensure renewal, you can join me next week and check that box with confidence. In August, we have 4 new webinar topics. Check out the CPTA website for more details. And then the last thing, please complete the evaluation form that is being sent to you at 8 p.m. this evening. This is the perfect opportunity to let us know what topics and speakers you're interested in. Our schedule is completely full and booked for the rest of the year. So I'm looking at speakers for the first quarter of 2026. So if you have any ideas, let me know. Be happy to talk to you about it or explore that a little further. So this does conclude our webinar for this evening. I'm going to stop the recording, but I'll stick around for a minute in case anybody has any questions.